Good afternoon. I'm going to talk about antenatal betamethasone for women at risk for late preterm delivery. My name is Nicole M. Okay, so continuing. Infants who are born at 34 to 36 weeks of gestation, let's say late preterm, at a greater risk for adverse respiratory and other outcomes than those born at 37 weeks of gestation or later. It is not known whether the betamethasone administered to women at risk for late preterm delivery decreases the risk of neonatal morbidities. So the methods are that we conducted a multi-center randomized trial involving women with a single-tone pregnancy at 34 weeks and 0 days to 36 weeks and 5 days of gestation, who were at high risk for delivery during late preterm period, let's say up to 36 weeks and 6 days. The participants were assigned to receive 2 injections, one of betamethasone and another of a matching placebo for 24 hours apart. The primary outcome was a neonatal composite of treatment in the first 72 hours, the use of continuous positive airway pressure or high-flow nasal cannula for at least 2 hours, supplemental oxygen with fraction of inspired oxygen at least 0.30 for at least 4 hours, extracorporeal membrane oxygenation or mechanical ventilation, or stillbirth or still neonatal death within 72 hours after delivery. So here's a video.
Today we are going to talk about a clinical case. Contracting Susie came in at 1 a.m. this morning. She is a G3P0202 at 34 weeks 1 day, and her preterm deliveries were at 34 and 36 weeks. Upon evaluation, she is noted to be contracting every 2 to 3 minutes, and she was 2 centimeters dilated. Guess what I did? I gave her antenatal betamethasone. Yepers, that is now a thing. The antenatal late preterm steroids trial, published in the New England Journal of Medicine, was a large, multi-centered, randomized controlled trial that demonstrated benefit to the administration of antenatal betamethasone for pregnancies at high risk for late preterm birth. Thank goodness for level 1 evidence, because I sure know this is something I was wanting to do all along. It seemed like what made sense. And now we have the evidence-based guidelines to support it. At the beginning of April, ACOG issued a practice advisory co-signing on the recommendation for antenatal betamethasone from 34 weeks and 0 days to 36 weeks and 6 days. So what were the findings? They noted decreases in respiratory complications such as TTN and decreased use of postnatal surfactant, decrease in the need for immediate postnatal resuscitation, decrease in the proportion of prolonged NICU stays. There was no adverse outcomes such as sepsis and chorio. Hypoglycemia was more common in infants exposed to betamethasone, but it did not correlate with any adverse events or prolongation of NICU stays. Essentially, blood glucose monitoring is recommended in infants in that gestational age anyway. Now, before some of you go overboard, here are a couple things that we should not be doing. At 34 to 36 weeks, do not tocilize or keep sick people pregnant, i.e., if your patient has chorio or severe preeclampsia, don't keep her pregnant just to get the steroids on board. If a patient has already received steroids, rescue steroids are not indicated between 34 and 36 weeks. At least not until we have the level 1 evidence to support that as well. Also, this trial did not include multiple gestations or diabetics, so we need to be on the lookout for more research in the future. I'm assuming ACOG will drop something in the near future on antenatal corticosteroid use. All right, that's all I have for you today. Subscribe to our channel.
Alright, so next. The results. The primary outcome occurred in 165 of 1,427 infants in the betamethasone group and 202 of 1,400 in the placebo group. Several severe respiratory complications, transitachypnea of the newborn, surfactant use, or bronchopulmonary dysplasia also occurred significantly less frequently in the beta-metoxona group. So there were no significant between-group differences in the incidence of chorioamniotis and neonatal sepsis. Hypoglycemia was more common in the beta-metoxona group than in the placebo group.
Doctors have prescribed steroids to pregnant women at risk of preterm delivery for decades. But what about those at risk of late preterm delivery? I'm Shelby Cullinan with your latest health news. In preterm delivery, or delivery before 34 weeks of pregnancy, one common fear is that a baby's lungs won't be sufficiently developed, which can be lethal. Doctors often prescribe corticosteroids to women at risk of preterm delivery because these drugs can accelerate an unborn baby's lung development. But in women at risk of late preterm delivery or delivery between 34 and 36 weeks, steroid prescriptions are much less common, likely because babies delivered at this stage have much higher survival rates than babies delivered earlier, according to a press release from Columbia University Medical Center. Still, late preterm babies have increased rates of respiratory problems compared to babies born at term or 37 weeks or later, according to this study. That's where a steroid prescription for pregnant women at risk of late preterm delivery could step in. Lead study author said in a press release, quote, "Our study demonstrates that administering a medication that is commonly used to prevent complications in babies born before 34 weeks of gestation can also reduce the risk of many serious complications in babies delivered just a few weeks before term." Speak to your doctor about the risks and benefits of steroid prescriptions.
So, conclusion. Administration of beta-metoxona to women at risk for late preterm delivery significantly reduced the rate of neonatal respiratory complications.